Hello, good morning, good afternoon, good evening, everybody, wherever you are joining us. My name is Francisco Viedo. I'm a member of the Housekeeping Global Board, and today I'm going to have the honor of chairing this session on using performance-based finance to improve health systems performance. A brief introduction about our session. The World Health Organization has defined performance-based finance, or PBF, as a form of incentive where health providers are totally or partially funded on the basis of their performance to meet targets or undertakes specific actions. It's also known as fee for service, conditional on quality. In many low and middle income countries, PBF programs are being implemented with the support of development departments and are referred also as paid for performance, P4P, or result-based finance, RBF, and are seen as a step forward in the process to moving towards a more strategic purchasing process for years health coverage. Today, we are going to hear different presentations from different parts of the world, from places that's different as sorry. I was saying that today we are going to hear from presentation from different parts of the world, from places as diverse as Africa, Latin America, the Middle East, and also Asia, where PBF strategies have been developed, and we have get a variety of results and different experiences from each setting. With Not further presentation, I just would like to remind a few housekeeping rules before starting the presentation. We are going to have a Q&A section at the very end of the presentations. For that, we have the chat box, especially for that on the platform, on the website. So I would like you to kindly deliver us your questions there. You can address your question to the whole panel or just to a particular panelist. And after all the presentations are done, we will go and review all the questions you have shared with us. In case, because of the time constriction, we don't have enough time to cover all the questions you will give in to us, you can address after the session directly to every presenter through the contact information they will provide, or also you can use the website and the app facilities to reach the presenters. Having clarified that, and with no further instructions, I would like to welcome our first presenter, Martina Chenga. I'm sorry, the pronunciation of your last name is not proper. She's from the Overseas Development Institute from the Ministry of Health and Sanitation of Sierra Leone. And she will present her work on the performance-based finance, what can be learned from Sierra Leone experience. Could we please play the video? Thank you.
Hi, my name is Martina Nchenga. I'm the Overseas Development Institute Fellow with the Ministry of Health and Sanitation in Sierra Leone. I'll be presenting on a paper called Performance-Based Financing, What Can Be Learned from Sierra Leone's Experience, which is a collaborative work with the Health Financing Unit team. So my presentation is outlined as follows. I'll start off with a study context, and then I explain a bit more on PBF in the Sierra Leone context, and then I'll also talk about the impact and the challenges that the country has so far faced and the way forward. So Sierra Leone is pretty much a very small country with a population of a little over 7 million, and it has really one of the worst maternal and child health indicators, with only 21% of the population having access to contraceptive, and about 75 per 1,000 live birth of infant mortality rate. Under 5 mortality rate is at 122 per 1,000 live birth, and maternal mortality rate is at 717 per 100,000 live births. That's according to the recent DHS survey. Regarding the income and health financing, about over half of the population is poor, and the GDP per capita is only $534, and the government allocates about 17.5% to health expenditure, and only 11% of the total budget goes to the health budget, which falls below the Abuja declaration target of 15%. And the country also has one of the highest out-of-pocket expenditures, with households contributing about 61% of their out-of-pocket money towards the total health expenditure. So what is PBF? So PBF is a form of incentive whereby health providers are least partially funded on the basis of their performance to meet certain targets. It is an instrument of strategic purchasing to move towards universal health coverage. Sierra Leone implemented PBF in 2011 and focusing on 6 reproductive and child health and 9 cross-cutting indicators. So the 6 reproductive and child health indicators include family planning, antenatal consultations, self-deliveries, postnatal consultations, full vaccination of children under 1, and outpatient consultations for children under 5. The cross-cutting indicators include register kept up to date and accurate, health management information systems monthly reported, submitted to district health management team, and last month minute available and signed by the chairman, who is in charge of the primary health care facility, ward charts displayed and up to date, and all the other indicators that are there. So the timeline for the PBF in Sierra Leone, it started off with the implementation of free healthcare in 2010. The idea behind the free healthcare initiative was to reduce the burden of user fees from the most vulnerable population, which includes pregnant women, lactating mothers, and women with under 5 children. And because of that, access and utilization of reproductive, child, and maternal health services increased, which affected the quality of care. So in order for the government to empower or to strengthen the free healthcare initiative, they decided to implement the PBF so that quality of care could also be improved in the process. So PBF was implemented in 2011. It was a nationwide implementation with all primary healthcare facilities having PBF, and also 6 secondary hospitals also had a PBF. So what was the immediate impact? So the immediate impact was it led to increased autonomy, which led to better hygiene and up-to-date equipment and supplies. And it also led to increased or improved coverage and quality of health services through a result-oriented and motivated health workforce in order to attain the health-related Millennium Development Goals as of that time. So the challenges after an external verification was done, where there was weak verification mechanisms in data entry, because for you to know the impact of PBF, you need up-to-date data entry. So those things were found to be lacking, and there was limited funding as it was mainly donor dependent. The government was not involved in the funding of the PBF, which meant that it was not reliable or sustainable in the long term. And there was also lack of comprehensive list of output and quality indicators. As I've explained, there were only 6 indicators from the reproductive and maternal health side, and only 9 from the cross-cutting indicators, which are not comprehensive enough. And there was inadequate autonomy of health facilities, very weak involvement of the communities. So the communities were not actively involved or engaged in the PBF implementation process. There were also delays in the payment, often up to 1 year, delay in projects and incentives for staff, which somehow led to demotivation of the staff. There were also weak institutional arrangements which did not allow for a clear separation of functions. So why should PBF be considered as a broader health system reform to ensure that it's more sustainable and that it's implemented successfully? So the changes to think of PBF as a standalone scheme and not the part of the overall health system is its effectiveness is dependent on where the provider purchase on how the provider purchase arrangements are agreed upon. So there's need to think about how paying for performance can help strengthen the existing health systems. PBF approaches are systematic approaches which work best when embedded in the overall health system reforms, in which various pillars of the health system also needs to simultaneously be addressed, such as human resources, health information systems, pharmaceutical sector, and physical space for health. So in the case of Sierra Leone, for example, in Sierra Leone, PBF and performance-based financing, district health management teams and local councils were unequipped to carry out the verification procedures. So the verification was found to be a very costly exercise, accounting for almost 30% of total costs, and therefore was deemed to be unsustainable. But lessons can be learned from Zimbabwe, where they managed to reduce verification costs by 47%. And in Sierra Leone, there's need to strengthen existing systems, data entry officers working with the health management information systems to improve accuracy of data entry, and M&E units in DHMTs to equip them to carry out routine supervision checks. And there's also need to integrate with the integrated supportive supervision. In terms of financial management, studies have found that PFM issues at various levels are very crucial when it comes to successful PBF implementation. So improving the public financial management measures, especially at the district level, as it was done in Tanzania, it can help for successful PBF implementation. So there is need to increase flexibility of public financial management measures to allow output-based payments and also grant autonomy to facilities. There's also need to make an incorporation in annual budgets, the way they did it in Rwanda and Burundi, so that it shouldn't be donor dependent. For sustainability and long-term sustainability, PBF measures should be incorporated in annual budgets. There's also need for government to streamline government and donor money. There's also need to start financial management conversations between resources and results. So going forward, there's need for the government or Sierra Leone to adopt a minimum benefit package which consists of currently incentive services which are aligned to corporate objectives. So there's also need to move towards an output-based provider payment mechanism. There's need to institutionalize output-based payments into national budget and public financial management processes, and also put together internal and external funds in one basket in a transparent and predictable manner, and link this to the accomplishment of each task, which would hold various actors accountable for their performance under the same contractual framework. There's also need to tap into existing structures for integrating information systems for provider payment and developing affordable and cost-effective verification mechanisms. Thank you so much for your attention.
That was indeed a very good presentation from Martina, and actually I think that helped us to understand better the needs that we must have into consideration to develop and also to evaluate a performance-based financing program. Next, we're going to follow with our presentations. We're going to have a video from Miriam Kangu. Once again, sorry for the pronunciation is not proper. PhD candidate from the University of Ottawa, Ottawa in Canada, who is going to present her work on in the role of performance-based financing in promoting financial accessibility to maternal services towards achieving universal health coverage in Cameroon. Could we play the video, please?
My name is Miriam Kangu. I'm a PhD candidate in epidemiology at the University of Ottawa. I'll be presenting one of my papers today, the role of performance-based financing in promoting financial accessibility to maternal and child health towards achieving universal health coverage. So I want to acknowledge my co-authors, Alison Krente and Sani Yaya. So performance-based financing has been a trending policy in low-middle income countries, especially sub-Saharan Africa. And Cameroon adopted performance-based financing in 2017 as a national strategy towards achieving universal health coverage. So the impact evaluation result for Cameroon revealed that variables like antenatal care and skilled delivery were not impacted. And this is actually a main concern because these variables have not actually changed for the past 2 decades. There was also no change in formal fees, and we have to recognize that Cameroon has very high out-of-pocket expenditure, and these are one of the reasons why performance-based financing was also introduced into the country. We know that impact evaluation actually could generate average effects, so they can potentially mask heterogeneity across health sectors, health facilities, and even health providers. So we actually see that the impact evaluation did not look at it from this perspective, even though public and private sectors were included in the impact evaluation, but the result did not generate findings according to sectors. So this study is filling this gap by looking at it from across sectors and see if there was any change. And in so doing, we are looking at it using another approach, pre-post, looking at data from the health facility before PBF and after PBF. And we also use the triangulation design, which is mostly used when you want to look at results from another perspective, and also when the subject matter is complex and highly contentious. And PBF actually fit into this because it's a complex health reform and also highly debatable. So we collected data across public and private sectors, and we also conducted in-depth interviews from women who have used the services, and also focus group discussion from the husbands of the men. So we use the Anderson behavioral model to look at health-seeking behavior of the women in relation to ANC and skilled delivery across health sector. So we looked at the cost before PBF and the cost after PBF from the various health facilities. And then we were looking at if there was any difference and any change in terms of the cost, and we put it in terms of percentages. And then for the in-depth interview, we actually used thematic analysis to analyze the data and across health facilities and looking at it from their health-seeking behavior. So we put the results together and interpreted it. So you can see this first slide is the public health facility. So in the public health facility, we noticed that costs actually increased, and this increase is also in the private conventional facility. So you can see that the cost increase, this is in CFA France, almost by 30%. And the rationale for this increase was the introduction of additional tests like hepatitis B, and also C-section increase. And the rationale was the use of disposable sterile garment. But echography dropped, and ANC 2 to ANC 4, the price didn't change. So what is important to note here is that this increase is across all income levels. So, and only those who will be considered poor and vulnerable, we actually get a reduction, because in this context, poor and vulnerable, according to PBF, their costs can either be subsidized or actually waived completely, depending on the health facility. Is the discretion of the health facility to decide on that. And these are the costs that women reported. And what they reported actually aligns with what we collected from the health facility. We only looked at the minimum and maximum costs that they reported because women shop around a lot. So most of the health facility that they delivered in was not the facility that they actually did their ANC. And you can see that the minimum and maximum also align with what we collected from the health facility. And only in this slide, we can see only the for-profit facility that prices dropped. So it dropped because this for-profit facility already have very high out-of-pocket expenses. So with the introduction of PBF, the cost actually dropped, but it did not with confessional and public. And these are the facilities that actually receive more of the women. So looking deeper into the Anderson behavioral model, we looked at it to understand ANC1, what are the variables that actually determine their use in different sectors, public or private. and we noticed that costs actually influence where they will go for their AMC. But when it comes to skill-based delivery, quality of care was the main component, and women actually reported the need to actually reduce the cost for ANC, and also the importance of improving on quality of care, especially amongst nurses. So in the private sector, in the public sector, women will report how it's the way they are treated during ANC1, it's already enough for them to avoid going there during skill-based delivery, because they imagine if they are in pains, what they will be doing to them at that point in time, like during labor. So that's why they will prefer to go to the private sector, even though the cost is high. So in a nutshell, we are concluding that performance-based financing is an add-on payment mechanism and not to an existing salary system. Therefore, there is a need to look at the intervention strategies. PBF may have introduced quality indicators, but these quality indicators in turn increased cost, and there's no mechanism to address that, even though there is the introduction of poor and vulnerable, but we don't know how this equity instrument is actually being implemented and if it actually targets the poor and vulnerable. So there is a need to prioritize ANC1 and C section, and also reinforce quality of care in the curriculum of health professionals, especially nurses. And further research needs to actually disaggregate data by sector to be able to look at heterogeneity across health sectors and health facilities. Thank you.
Thank you very much for this very good presentation. And I think that this shows us how PBF evaluation can be also used as a tool to measure the changes that can be achieved on access health intervention and the coverage of the interventions in every setting. Very, very illustrating presentation. Moving forward, now we are going to have a presentation by Jade Khalife, health system practitioner and researcher from the American University of Beirut, also a member of the Lebanese Ministry of Health. And he will present on the experience of hospital performance and payment, the impact of integrated pay for performance on healthcare systems effectiveness in Lebanon. Could we play the video, please?
Hello, everyone. I'm going to be sharing today about hospital performance and payment, the impact of integrating pay for performance on healthcare system effectiveness in Lebanon. I'm Jade Khalife, and this project is a collaboration between the American University of Beirut, the Health Ministry in Lebanon, and Lund University in Sweden. And these are my colleagues on this project. And I'd also like to acknowledge the funding agencies for this ongoing project. So this is basically about hospital pay for performance for the purpose of improving patient outcomes, equity, and efficiency, targeting Lebanese public and private hospitals, using pay for performance to set reimbursement tiers. And some of the particulars are the use of case mix index, which is a measure of complexity, case complexity, hospital performance using non-bonus incentives, and the use of routine data. So hospitalization in Lebanon, briefly. Since 1962, the Health Ministry has covered all citizens who otherwise do not have any health insurance. This presently accounts for about 52% of citizens, and in most cases also includes a 10 to 15% co-payment from patients. To deliver these services, the Health Ministry contracts 146 private and public hospitals. So hospitalization overall accounts for a large proportion of the total health expenditure in Lebanon, as well as the majority of the Health Ministry's budget. And there's been numerous hospital sector reforms over the past several decades. particularly the linking of rating and reimbursement in the 90s. And since 2001, in several stages, hospital accreditation, which was then used to directly link with the payment, the reimbursement rates or tiers given to hospitals. In 2014, the development was moving on to a mixed contracting model. So going back to what was the problem, and it was mainly the health ministry's limited capacity to monitor the actual service delivery happening at hospitals, which is a classical principal agent problem. Accreditation results were used to set 3 reimbursement tiers, but our investigations into this found that this was insufficient and inappropriate. There was wide variation in terms of the complexity and of hospitals within each or of cases within each of these reimbursement tiers. So the whole logic that the system was built on was unfair in some ways to some hospitals. Surgical cases are paid based on a flat fee, a structure, a predefined flat fee. Medical cases are based on a fee for service. We knew that there was misuse and abuse of hospitalization, particularly reflected in a lot of unnecessary hospitalizations. Case complexity was not really captured properly within the system. And we wanted to provide policymakers with a tool to incentivize the improvement of hospital performance and patient outcomes. In 2014, the model that was based 100% on accreditation results determining the reimbursement rates was developed further, so that accreditation accounted for 40% of the total contracting score. 35% was of the total contracting score was based on the case mix index, the hospital case mix index, or the average complexity, case complexity of a particular hospital, and 10% on patient satisfaction, and the remaining 15% on other minor factors. So the performance results were then used to categorize hospitals across the 3 reimbursement tiers, T1, T2, T3. So our questions were, did the 2014 reform improve the effectiveness of the hospitalization system? And we wanted to see how we could use the routine data and case mix index to incentivize or for hospital performance purposes. We used interrupted time series analysis on a data set including 1.3 million cases across 146 hospitals, in cases which occurred from 2011 till 2016 under the Health Ministry's coverage. This allowed us to have 72 monthly data points for case mix index, which was sufficient for appropriately analyzing the pre-intervention and post-intervention periods and the possible impact of the intervention. We also stratified by hospital ownership, whether it was public or private hospital, and by case type, whether it was a medical, surgical, or mixed case, which is mostly ICU, intensive care unit cases. We also followed the interrupted time series analysis with code level analysis. We didn't just want to identify whether or not a significant change had occurred due to the impact, due to the intervention. We also wanted to understand where this change was happening, across which medical cases and across which diagnoses and which surgical procedures. So on the top left corner, you can see the short stay medical cases among public hospitals and their case mix index. The red dot lines stands for the intervention. So across public hospitals, and under that also in green among private hospitals, we can see the impact of the intervention on the case complexity. And on the top right-hand corner among medium stay medical cases, 2 to 15 days, among public hospitals and among private hospitals under that. And we can see in terms of the impact of the intervention happened both, particularly among medical cases, and it happened in terms in 2 ways: trend changes as well as level changes of the case complexity of the case mix index. Looking across medical cases, we could see that the pre-intervention decreasing trends among medical cases were replaced with increasing trends, monthly trends, in terms of case mix index. Among the trend changes, the positive trend changes were explained by medium stay cases, mostly by medium stay cases, and were due to decreased cases of diarrhea, gastroenteritis, abdominal pelvic pain, essential hypertension, and fever of unknown origin. Most of the level changes, which were as a result of short stay cases, were due to improved coding practices, particularly for cancer diagnoses and codes. In conclusion, we had much more limited impact in terms of surgical or mixed cases. In conclusion, we found that the 2014 intervention increased the effectiveness of the healthcare system. This was mostly due to decreased unnecessary hospitalization and improved coding practices. Effective hospital regulation can be achieved in limited resource settings through systematic collection and analysis of routine data. We can use hospital case mix appropriately for performance as a performance measure. And the future steps are for evaluation of the 2019 future development of this model and the ongoing additions to this. The below mentioned paper also includes further details. Thank you for your time.
Thank you, Jade, for your presentation. Really interesting. I think that from that we can take that definitely PBF can be used not only on outpatient settings, but also definitely in inpatient facilities. And it's a really good tool to help on solve and improve the quality and management of the services. Before moving to our next presentation, I would like just to remind our housekeeping rules regarding the questions. We are not taking questions right now, and the way that we are going to take questions, it's through the live Q&A facility on the website. So please share with us your question there, and at the end of all the presentation, we will address all the questions you have shared with us. So please just go there to the chat box of the live Q&A facility, and then we will come back to you at the end of all the presentations. So moving forward, now we are going to have a presentation by Li-Ling Liang, assistant professor at the National Sun Yat-sen University in Taiwan. She will be presenting her work about the effect of pay for performance on screening interval, stage of the diagnosis, and mortality among patients with liver cancer, 18-year cohort study. Please, could we play the video? Thank you.
Hello, everyone. Today, the topic of my presentation is effect of pay for performance on screening interval, stage of diagnosis, and overall mortality among patients with liver cancer. This is an 18-year cohort study. I'm Li-Ling Liang. My co-authors are Lin Yixian, Wu Zhenyi, and Wu Junying. So why this is an important topic? Because pay for performance has been widely adopted as a key strategy for value-based purchasing. However, the effectiveness of P4P to improve patient outcomes remains controversial. So the aim of this study is to investigate a hepatitis P4P program introduced by Taiwanese government. The program rewards physicians for regular screening and early diagnosis of liver cancer. We call it HCC. And we want to see if the program could reduce mortality of patients with HCC. So as I said, this is a nationwide cohort study. The study population are patients newly diagnosed with liver cancer between July 1st, 2012 and December 21st, 2015 in Taiwan. The program was introduced in 2010. So we omit the first 2 years because in those initial years, the implementation is not quite in place. And we want to select among those patients, those who participated in the program is classified as the P4P cohort, while the rest are classified as non-P4P cohort. And because these two cohorts may look very different, so we used propensity score matching to ensure that they are as similar as possible. We matched those patients on the basis of their age, sex, baseline comorbidity, use of antiviral therapy, whether they were treated at private hospitals. And we tracked them back to 2000. So we have like 10-year baseline period from 2000 to 2009. Our main outcome is 5-year overall mortality, and our secondary outcomes are screening interval, which is defined as the number of days between the last ultrasonography examination and the date of HCC diagnosis. And the other secondary outcome is HCC stage at the time of diagnosis. These two secondary outcomes are incentivized under the P4P program, but our ultimate goal is to look at whether these incentives improved or we say reduced the overall mortality of HCC patients. And we used the Kaplan-Meier method to calculate the mortality, and we applied Cox proportional hazard model to examine the effect of the P4P program. So here are the results of matching. P4P cohort include 4,363 patients, and the number in the non-P4P cohort is doubled because we used 1:2, the matching criteria. And we discovered that age, sex, hospital type, antiviral therapy look like the distribution of these variables are very similar between the two cohorts. However, in terms of the comorbidity, these two cohorts do look a little bit different. So we definitely control the comorbidities in our Cox proportional regressions. And when we look at the events or we say outcomes after matching, we can find that P4P cohort does have a shorter screening interval. For example, there are 45% of P4P patients received screening within 6 months, whereas the ratio is much lower. It's only 26% for the non-P4P cohort. In terms of the HCC stage, around 60% of P4P cohort were diagnosed at the very initial stage, which is stage 1, whereas only 43% of non-P4P cohort patients were diagnosed at the stage 1. Okay, so from this basic comparison, we can find that, yes, the incentives does work. And when we look at the overall deaths, the mortality rate is lower for P4P than the non-P4P cohort. And this figure shows the cumulative incidences of overall mortality. The blue line shows the P4P cohort, and the red line shows the non-P4P cohort. The x-axis is the number of years up to 5-year follow-ups, and the y-axis is cumulative incidence. And the red line is higher than the blue line, which means that the non-P4P cohort has much higher cumulative incidence of mortality compared to the P4P cohort. And finally, we developed 3 empirical models to look at the effect of P4P. The key variable is an indicator for P4P cohort versus the non-P4P cohort. And if the hazard ratio is less than 1, then this means that the P4P cohort has lower mortality. Our Y variable is mortality. And so for model 1 is the most basic model. We only include baseline characteristics. And model 2, we include the screening interval. And model 3, we include not only baseline characteristics, but also interval, HCC stage, and HCC treatment. So model 3 is our preferred model. And in this model, the hazard ratio is 0.86. which means that the P4P cohort has lower mortality than the non-P4P cohort. The p-value is very significant. But an interesting thing is that we can find the hazard ratio increased as we include more variables in the regression model. So this has an important implication. This means that the beneficial role of the P4P program is likely to work through shorter screening interval and early diagnosis. So when these two variables are included in the model, the difference between the two groups in terms of the mortality rate is not so big compared to model 1 and model 2. Okay, so the main conclusion is that compared with the non-P4P cohort, the P4P cohort had more frequent ultrasonography follow-up screenings or diagnosed at earlier stages and had lower cumulative incidence of overall mortality. So the program really works. And incentivizing both regular screening and early diagnosis may increase the survival of patients with HCC. So this is my presentation. Hope you enjoyed it. Thank you.
Thank you very much. It was a very good presentation. I think it helped to reinforce the idea of the variety of different interventions that can be used to evaluate the PVF or P4P programs, and also that these kind of evaluations actually can be used to determine the effectiveness of the interventions we are delivering. Next, we are going to have our last presentation from Akin Tafatsawa Lupa. Once again, sorry for the pronunciation if I make a mistake or the last name. He's from the University of Cape Town in South Africa, and he's will be presenting about the inequalities in utilization of maternal health services in Zimbabwe. Please, could we play the video? Thank you.
The study assessed the decomposed inequalities in skilled birth attendance in Zimbabwe using 2010 and 2015 DHS datasets. My presentation outline looks like this. We've got the background methods, results, discussion, take-home messages, and concluding remarks. Just to give a little bit background on maternal health inequalities globally, the Sustainable Development Goals are advocating of not leaving anyone behind, with more countries moving towards universal health coverage. However, sub-Saharan statistics show that about 162,000 women still die every year during pregnancy and childbirth, with majority of these deaths attributed to lack of skilled birth attendance at delivery. Therefore, it is important to notice that an improvement in the uptake of skilled birth attendance plays an important role in reducing maternal deaths. Zimbabwe is located to the south of Africa and is part of sub-Saharan Africa. 2011 statistics reported that 10 women died every day due to pregnancy-related complications, with an equity analysis done in 54 developing countries, including Zimbabwe, reporting a 52% difference between the wealthiest and the poorest population quintiles. Therefore, this study assessed the trends of socioeconomic inequalities in the uptake of skilled birth attendance in Zimbabwe, comparing the two time periods, that's 2010 and 2015. Skilled birth attendance was defined as a health personnel who had midwife training, either a nurse, a midwife, or a doctor. Then we computed a binary logistic model to understand the relationship between skilled birth attendance and some explanatory variables. Then we used the Eric Ray's normalized indices and decomposed them to understand socioeconomic inequalities between different socioeconomic classes. Our results showed utilization of skilled birth attendance by workers and residents to be more dominant among poor rural women. And antenatal care, women's age, employment, household, head, sex, place of delivery, residence status, and birth order were significant important predictors of skewed birth attendance. And our computed odds ratios showed that women who had at least 4 antenatal care visits and their husband were educated, with them having attained at least secondary, were more likely to use skilled birth attendance services. However, the high birth order reflected that women who had given it at least more than 2 times were less likely to use skilled birth attendance. This just gives our concentration indices report. You see the absolute difference reflect that socioeconomic inequalities are continuously increasing in Zimbabwe as we compare the 2 time periods across skilled birth attendants and across health personnel. We know that we can actually see that our indices increased, as well as our concentration curve just give a graphical picture of our concentration indices. Something to note is those who were assisted by a midwife, it reflects a reduction in the pro-rich gaps, as in 2010, midwives were more likely to assist the rich, but in 2015, they're more likely to assist the poor. Then our decomposed results reflected that household wealth and place of delivery, as well as resident status, were major contributors driving socioeconomic inequalities in skilled birth attendance. However, in 2015, the household wealth disappeared, with only antenatal care, education, resident status, and birth order main drivers of socioeconomic inequalities in skilled birth attendance. Our study results showed findings of wealth-related inequalities in Zimbabwe, and the concentration index for aggregated skilled birth attendants were pro-rich, implying women from rich households were advantaged in the uptake of SBA services in Zimbabwe. However, when assessed by health personnel, the inequalities varied, favoring the poor and the rich across health personnel. The study decomposed results reported household index as household wealth as one of the major drivers of health inequalities of skilled birth attendance, since the findings are generally high skilled birth attendance usage among rural women. Our take-home messages will be household wealth. There is existence of socioeconomic inequalities in skilled birth attendance, and the pro-rich gap appears to be widening, as reported by the concentration index. Then when we look at women's education, we notice that in the both periods, educated women were more likely to be attended by skilled birth attendants. So even though Zimbabwe is still a developing country and reporting a very high literacy rate, there still needs to continuously engage and invest in educational policies that target women, especially from poor and deprived households. Then lastly, maternal health information should also be given in the form that is easy to understand and accessible to users of the services, especially the poor. Decomposition analysis across the survey years showed household wealth index, husband education, women's education, and resident status to be important contributors of skilled birth attendance, which is one of the main things that has been highlighted by this study, that indeed socioeconomic status is a major contributor in maternal health differences across socioeconomic groups. Therefore, the study concludes that an effective way to reduce the health inequalities is not only to narrow the gap of income between the rich and the poor, but also to focus on educating women on the importance of maternal health service usage. With that, I thank you.
Thank you very much for the presentation. I think it was really illustrating about how inequalities of health, it's driven not only by the healthcare facilities, but also the social determinants of health, education, economic status. It's problems that we have there, and we definitely must to overcome and work hard to try to diminish these inequalities that we are still seeing in many different settings. I would like to thank all the presentations, all the presenters who have delivered and shared with us their work. I would like just to make a clarification that we have another presentation according to a program. However, and unfortunately, the video was not recorded in English, so there was no accessibility to it for today's session. Just to clarify that. And we have these slides from this presentation. They're on English, and we would like to share them with you after the session it's over. But sadly, right now we cannot share the video. Okay. Now we would like to move to the Q&A part of the session. We have a couple of questions on the chat box, but before going to those specific questions, I would like just to make a final summary of all the presentations and the experience has been shared with us. And I just like to start stressing the really interesting approach we have seen across the different settings that we had seen. We had seen that PBF can be used not only as merely a mechanism to set finance problems or financing issues of the health systems, but also it's a really good tool to try to improve the quality of services, the effectiveness of the intervention, and to evaluate how well we are performing as a health system in general. And in a variety of settings, as outcare patients, also patient facilities, and to also variety of different kinds of intervention, from maternal care to chronic disease care, and the regular day-to-day intervention we perform in hospitals as surgeries or intensive care unit. So I think it's really important to see how all these presentations have reinforced that value of PBF or P evaluations and programs to excel and improve the effectiveness of the health system as a whole. We have we have more questions now. That's good. Our first question is for all the panelists, and it comes from Ayat Abu Agla, and he said that thank you for to the panelists for the interesting presentations. A question to all the panelists. From your studies, how good you propose measuring performance of the HWF, I think is the health workers force that's being referred to. So I would like to give the space to the panelists to talk about that, how to evaluate the performance of the health workforce using the PBF tools. I don't know, maybe Miriam, would you like to go first to answer this question? Miriam, please unmute yourself. You're on mute. We can see you, but you're on mute. Yeah. Go ahead.
Okay, sorry about that. So thank you for the question. And I just want to be clear about it. So the question was, how can we use PBF to evaluate health workforce?
Yes.
Is that the question?
Yeah, the performance of the health workers.
Oh, okay. So based on my own experience, I was actually focusing more on the cost aspect of PBF during my research, but I think there are indicators already that are available to address some of the activities of the health workers or providers. And it is based on those indicators that PBF is able to evaluate to understand how the health provider is performing in terms of individual and the health facilities, because they have what they call quality bonus and performance bonuses. But these indicators are what they are being used to evaluate, and depending on the criteria set by, because this is contextualized depending on the country and depending on the setting. But based on my experience while conducting research, I also think that there is the need to not look at it only from the level of the indicators that are being designed and at the level of health facilities within the PBF, but they should look at a continuum in terms of PBF is improving quality of care, yes, but this is something that is being implemented within an existing health system. And these health systems, it's not enough to try to improve the quality of care of health providers in a system that maybe I will look at it from the perspective, the curriculum, how is the curriculum of health providers set up in that system? How are they trained? Are they trained from looking at quality of care also as a priority? Because trying to introduce quality of care at this implementation level in their profession when they're already in practice is good, but it's not enough to sustain the continuity of that approach. So I believe one thing I found is that they should also look into how to incorporate quality of care in the health training program of healthcare providers, and try to emphasize on that, because that is what they will be focusing on measuring when they are in practice. And in that way, it can ensure some kind of performance measures and strategies. So that's something I think I can add to that. So I don't know if any other person have additional inputs.
Thank you, Miriam. I will ask our other presenters to go. Jade, you'd like to address the question about how to evaluate the performance of the health workers? And also, I would like to ask all the presenters, if possible, for them to turn off the cameras to this part of the session, and so we will make a little more interactive. Akin and Lillian. Jade, please go ahead.
Thank you, Francisco. Yes, I agree very much with what Miriam said. Our own work has been at the level of institutions, of hospitals, and that has its own set of complexities and issues. And I think also when you work at another level, at the level of healthcare professionals, that introduces its own set of issues or complexities. So it goes with, I mean, it has to be contextualized and depending on how the intervention or integration of such an initiative is made, how it is designed, because there is some evidence from the literature where we can see negative effects when the design is not appropriate or the incentive scheme is not appropriate. And because healthcare professionals can have a more negative outlook sometimes for monetization of certain services, whereas for others it can be very positive. So this is, I think, from my end, but specifically I think someone else might be able to add further to that.
Thank you, Jade. Lillian, could you like to share a little bit about your experience of the evaluation of the health workers' performance using the PBF tools?
Yes, my work is about Taiwan's pay for performance, and I think it's very important to have a national database in order to monitor performance of the provider performance. And because Taiwan has always collecting data on diagnosis, procedure, and reimbursement. So we are quite easy to monitor the performance of healthcare workers, especially physicians and hospital doctors. So I think the point for country that already have a very good database is how to design a good performance measure that could maximize the benefit of patients, because sometimes financial incentives for the physicians can have a negative impact on patient outcome if physicians overly focus on those dimensions that have been monitored and ignored other unmeasured dimensions, which may be also very important for patient outcomes. So in my case, the P4P program in Taiwan has a very good design in my personal view, because it rewards physicians for guideline recommended processes. So that would align physician action with the best practice. So that's my reflections on this question.
Thank you very much, Lillian. Akin, even your presentation was not specifically on the field of PBF, but I think that, as you mentioned, the inequalities are even because of many different factors. And I think the performance of the health workers could be one of them. Maybe could you like to expand a little bit if you explore that in your research about the performance of the health workers being a factor that influence on the inequalities that you watch in your setting?
Thank you so much. Definitely. So you can see, I think in most countries, especially developing countries, you would notice that less people are more likely to use public health facilities, on the notion of that public health workers are usually undermotivated and they don't have the capacity to perform fully. So definitely it's quite a cause of concern that affordability and the quality of services that is actually offered at institutions, public and private, it basically varies because of that. So in my argument, yes, health workers or health systems actually influence the use of services. That's why we have people who don't have money going to the public health facilities, basically because they can't afford private care where there's better quality and better service utilization.
Thank you, Akin. And thank you everybody for your question, for your answer to this question. I think I hope that it was being covered. What sorry. Our next question is from Martin Orange, and he is saying that it was interesting to hear about the PBF in Cameroon through increased quality standards has led to increased out-of-pocket expenses at the public and conventional facilities, while the expenses at the private facilities have decreased. The presenter mentioned that it was due to the elevated costs at the private facilities before the PBF intervention. But what caused the decrease? Miriam, would you like please to address this question about what caused the decrease on the private facilities or the out-of-pocket expenses? Sorry, please go ahead, Miriam.
Yeah, thank you. Actually, from what I gathered from the field, for the private for-profit, because there are two types of private here. We have the private confessional, which is mostly the faith-based, like Catholic and Presbyterian, Baptist. So, but the decrease overall decrease was more from the for-profit, because for-profit facilities are already very expensive. And so they are for profit, so that's why they are expensive. So with the introduction of PBF, most of them decreased their costs because of the attraction of the poor and vulnerable bonus. So which means that the decrease is to attract this poor and vulnerable population to be able to afford the services, even though the decrease is not really a decrease per se. If you compare it with the public and private sector, the cost is still high. But when you look at it from the for-profit sector, you see that before PBF and after PBF, their cost has dropped. So in this private for-profit sector, most of these quality aspects are already incorporated in their cost, because, for example, the skill-based delivery cost increased due to introduction of disposable sterile garment. But in for-profit sector, these things are already considered during skill-based delivery. So it's incorporated in this cost already. And this cost now is like very high, because in CFA France, skill-based delivery is not less than $100,000, sorry, 100,000 francs CFA. Now, with the introduction of PBF, some may reduce it to like 80,000 francs, for example, but 80,000 francs is not what you pay in a public facility. So the decrease is more from what I found to attract poor and vulnerable, so they can use more of their services. And in return, it also gives them more of the poor and vulnerable incentives. That the question is, how many poor and vulnerable are actually using the services with this reduction? And how do they define poor and vulnerable in that context, which is what my next project is looking at.
Wonderful, Miriam. I really wish the best of luck in your next project. I hope that result will be as good as the present one. We have another question. Also, this is also specific to one presenter, is to Akin. It's from Sia Agray. And the question is, do you think the enhancement of agricultural extension services can be one of the pathways to narrowing inequities in healthcare access? Akin, would you like to address the question?
I think specifically maybe when we look at around food security and nutrition, yes, it might be a good tool to use agriculture extensions. But if you look at the other socioeconomic inequalities, which are on top of our public health problems within low to medium income countries, which is basically maternal health services, your skilled birth delivery, and antenatal care and so forth, you'd find that introducing agricultural extension programs does not do much of a change, or is not much of a big influence compared to if we want to focus it on food security and nutrition. So my answer will be yes, it depends on what we are really targeting. But if it is the other components of health inequities or inequalities, I think it will have less impact. It will work more when we're focusing on food security or malnutrition as health problems.
Okay, thank you, Akin. We are approaching to the end of our session. We only have a few minutes left, and we have one more question. This is addressed to all the presenters, so I will just request for you to be as precise as you can, so we all can share our point of view of that. And the question is coming from Sarah Bruce, and she says that robust documentation of medium and long-term effects of PBF on health systems remain quite scarce and tend to show that it weakens the health systems. It also heavily relies on donors' contribution, which challenges the sustainability of such a scheme. It would be interesting to hear the balance of this. I think that, just to summarize the question, is about sustainability of the PBF and the role of depending on donors' contribution, especially as in now in our current situation that many donors are going through financial difficulties. That's a very interesting aspect. So maybe to follow the same path, Miriam, then Jade, Lillian, and finally Akin, would you like to give us your inputs on this? Miriam, please go ahead.
Thank you. So I will just speak for Cameroon because currently Cameroon has institutionalized PBF. So it's actually being implemented across all the health facility. And I from what I've gathered in my field, I see that it's not funded 100% at this point in Cameroon by donors, because most of the input budget that Cameroon used to use for input services, they've now transformed some of this budget to pay providers according to these PBF bonuses. So I know in Cameroon now, sustainability, it's more on the way they've redistributed the budget. So before, like 80% of the budget was at the national level, where no activity is being taken place. And then the operational level, which is at the district level, used to get just 5% of the health budget. But this situation has been reversed as a result of PBF, which is an important policy implication and decentralization. So that's an aspect of sustainability. And so for that reason, the government of Cameroon is looking into how to sustain these PBF payments, because at some point the World Bank will be, like, I think from what I gathered, by 2021, so, or 2022, something like that. So what is important is in sustainability is the political will. So if the country has that political will, then they will be able to sustain the PBF from donor funding, because they just need to restructure the budget of the country and look at where the gaps are and how they've been managing the budget before, and how they can actually harmonize it to sustain, and then have the necessary infrastructures to run that. So that's more of the political will and the structure of the budget, which I saw that in Cameroon to some extent.
Thank you, Miriam. Jade, please, could you share yourself in the question?
Yes, thanks. It's a very interesting question, and one that we could probably talk for days and days about. It is an issue, I mean, the sustainability and financing of such interventions. From our own experience in Lebanon, the situation or the issue of sustainability was not particularly relevant or high, because what we came in our experience, what we did was provide a solution for the health ministry and for private and public hospitals regarding on which reimbursement rates or tiers to contract the hospitals. The way it was designed was linking performance to reimbursement rates, not without using a bonus or penalty system in that sense. There was nothing external outside of the existing budget of given to hospitals by the health ministry. So in that sense, the long-term sustainability of what we did is not dependent on any external funding. One of the reasons also why we did this, and we mentioned some of these issues in the paper we published regarding the project on Welcome Open Research, is the issue of corruption, because we particularly also have that in Lebanon, and it gives a lot of challenges. In that sense, there would have possibly been a risk if there was a bonus kind of system with external funding coming in. Instead, it was linking the currently used funds and introducing much more transparency regarding how hospitals are classified into the top, middle, or lower reimbursement tier. It is, of course, this is one of the most important issues, of course, the sustainability in the long term regarding PBF. Thanks.
Thank you, Jade. Lillian, could you give us your thoughts about this?
Yes, I think time is almost up. So
Yes.
I would like to give this opportunity to the next speaker, if you don't mind. Yeah, I don't
Okay.
have special comment for this question.
Okay, thank you, Lillian.
Yeah, thank you. Thank
Akin, please, you have any thoughts on the issue?
All right, I'll try to be brief. So I think the most important take-home message should be we need to combine, PBF with complementary other investments so that we improve or amplify the effects of PBF as well as quality of care, because it's not a tool that can only be used on its own. We need it to be aided with other things. Otherwise, results-based performance as a tool alone within the health systems won't do much of a difference, but there's need for complementary tools to actually assist it in attaining or improving quality of care within health systems in countries.
Okay, thank you very much. And we're out of time. I just want to say thank you to all the presenters and also the technical staff who help us, and to all you who stayed with us during this presentation. I hope that has been really enlightening to you. And please, as I told you, you can continue contacting our presenters through the website or the application facilities, and also the links and emails they provide you during the presentation. Thank you very much and have a very good day. Bye.
Hola a todos y a todas, mi nombre es Alfredo Palacios y hoy quiero hablarles acerca de este estudio que busca evaluar el impacto de un programa de pago por desempeño en la mortalidad infantil en Argentina. Antes que nada es importante mencionar que el sistema de salud de Argentina tiene una serie de características muy particulares. Entre ellas es un sistema de salud altamente fragmentado en términos de financiamiento y cobertura de salud. Argentina es un país federal, por lo tanto la salud está altamente descentralizada desde la nación a las provincias y en algunos casos de las provincias a los municipios. Y en general en Argentina decimos que tenemos un sistema ineficiente porque gastamos aproximadamente el 10% de nuestro PBI y sin embargo nuestros resultados no son tan buenos. Además es importante mencionar que hay fuertes inequidades en ingreso, pero también en salud en nuestro país, principalmente entre distintas regiones geográficas. Vinculado al programa de pago por desempeño que voy a evaluar, es importante mencionar que en 2001-2002 Argentina tuvo una crisis económica y social muy severa, y eso llevó al país a pensar sobre nuevas políticas de salud. Entre ellas, surgió un programa de pago por desempeño que fue llamado Plan Nacer, el cual buscó cambiar un poco la tradición de financiamiento de la salud basada en presupuestos. Y este programa de pago por desempeño se focalizó en salud materno-infantil en mujeres y niños vulnerables. Entonces, el objetivo de mi estudio es tratar de identificar si este programa de pago por desempeño tuvo un efecto causal sobre la reducción de la tasa de mortalidad infantil a nivel nacional. Sobre los métodos, el método que yo utilicé se conoce como el método del control sintético, que básicamente lo que busca hacer es construir un contrafactual, en este caso una Argentina contrafactual, que surge como una combinación ponderada de posibles unidades de control, y es importante mencionar que mi nivel de análisis va a ser a nivel del país. Por lo tanto voy a tener una Argentina real con el programa de pago por desempeño, y construyo una Argentina sintética que actúa como un contrafactual que no va a tener el programa de pago por desempeño. En relación a los datos, construí un panel de datos en donde, como mencioné anteriormente, el país de intervención va a ser Argentina. La intervención, este programa de pago por desempeño comenzó en 2004 y este panel de posibles donantes está conformado por múltiples países latinoamericanos del mismo nivel de ingreso que Argentina. Cubre un periodo de tiempo de aproximadamente 25 años, considerando el periodo pre-intervención y el periodo post-intervención, y hay una serie de covariables de interés que utilizo para construir la Argentina sintética. Y las fuentes de información son múltiples. Lo que presento a continuación es un poco información pretratamiento sobre una serie de variables claves para ver cómo funciona mi Argentina sintética comparada con la Argentina real, la que tuvo la intervención, y también con el promedio de los países latinoamericanos y el promedio de los países de ingresos medios y altos, que es el nivel de ingresos de Argentina. Y lo que uno observa en general es que mi Argentina sintética, digamos el contrafactual que construí, parece ser mucho más parecido a la Argentina real que, por ejemplo, el promedio de los países latinoamericanos o el promedio de los países de medianos y altos ingresos, lo cual es un muy buen indicio acerca de que puedo haber construido un contrafactual válido para comparar qué sucedió en Argentina sin el programa. Este es uno de los principales resultados del trabajo. Acá, en primer lugar, les muestro un poco como la tendencia preintervención, digamos, entre la Argentina real y la Argentina sintética en lo que tiene que ver con la tasa de mortalidad infantil. Como pueden ver, en el periodo pretratamiento prácticamente no hay diferencia, digamos, entre la tendencia en la tasa de mortalidad la mortalidad infantil entre la Argentina real y la Argentina sintética. Si esto es correcto, entonces si yo identifico alguna brecha o alguna diferencia entre estas dos Argentinas, en el año posterior al año que comienza la intervención, entonces puedo decir que esa diferencia podría obedecer a un impacto causal del programa, y en cierta manera eso es lo que encuentro. Lo que encuentro es que esta Argentina real, representada por la línea azul, tiene una reducción en la tasa de mortalidad infantil más acelerada o más pronunciada que el control sintético, digamos, que la Argentina sintética. Esto que presento a continuación es la misma información que en la figura previa, pero expresada como una brecha, o sea, como una brecha en la mortalidad infantil entre la Argentina real y la Argentina sintética. Como vemos, hasta el año previo a la intervención, prácticamente no había ningún tipo de diferencia en la tasa de mortalidad infantil entre la Argentina real y la Argentina sintética. Sin embargo, cuando se implementa el programa, muy gradualmente comienza a mostrarse una reducción en la tasa de mortalidad infantil que llega en el último año a 1.3, 1.4 puntos porcentuales, que eso equivale a una reducción relativa de aproximadamente un 10%. Es importante mencionar que este resultado fue robusto a diferentes test de falsación o test placebo. No los presento en esta ocasión porque, por cuestiones vinculadas a la restricción temporal, pero sepan que realicé múltiples pruebas o test placebo para ver si ese efecto de la reducción de la mortalidad infantil de 1.3 puntos porcentuales, 1.4, era robusto a diferentes asunciones, y encuentro que sí. En general es robusto a los que se conocen como test de permutación, que esto es básicamente como ir sacando uno a la vez distintos países en el panel de donantes para construir nuevos contrafactuales, y ese efecto aparece igual. Y otros placebos o experimentos que se conocen como in-time placebo, que básicamente buscan como simular que la intervención se implementó antes de la fecha real o posterior a la fecha real para ver si existe alguna diferencia en la tasa de mortalidad infantil, y no. Y realicé también otra serie de experimentos placebo, y en todos los casos el resultado parece ser robusto. Finalmente, para presentar la conclusión y discusión de este trabajo, digo que según mis resultados, el programa de pago por desempeño tuvo un efecto causal al reducir la tasa de mortalidad infantil en aproximadamente 1.3, 1.35 puntos porcentuales, lo cual representa una reducción relativa de aproximadamente el 10%. Y este resultado fue robusto a numerosos test o experimentos de falsación o test placebo. Sin embargo, una limitación de mi trabajo es que los datos que poseo no me permiten identificar claramente cuál fue la razón de éxito del programa. O sea, el programa fue exitoso, pero es difícil identificar a qué se debió ese éxito. Puede haber sido la transferencia de dinero, puede haber sido la rendición de cuentas que tuvieron que hacer los efectores de salud, o quizás fueron todos, pero eso no está claro con esta información. Así que ese fue mi estudio. Les agradezco mucho por su atención y les presento mis datos de contacto por si quieren tener más información sobre esta investigación. Muchas gracias.